Good evening, everyone. I'm able to hear some echo. Anyways, I'll just proceed here. Thank you. Thanks a lot, Sir Nitin, for this opportunity. Sir, can you hear me, sir?
Yes, Dr. Akum.
I think I've just rejoined because there's a lot of echo.
I
Can
think
I
you
do
have
that?
joined on two. No, yeah, you have joined on two phones, I believe.
Oh, okay, okay.
Yeah, just
Just a second.
yeah.
So today, so hello, sir.
Yeah, Dr. Akum.
I'll go ahead.
Yeah, please start.
Okay, so we'll talk on the approach to a bleeding infant. I'm not able to control the slides. So first of all, thank you again. Next slide, please, sir. So are you controlling the slides?
Yeah, Dr. Akum, please. If there's a problem with your slides, then
Discuss some points on the bleeding in newborns, a case of bleeding child, as well as a massive blood transfusion. We will not be discussing about the details of the disease per se and the management. We will focus more on the approach. So before going to the details of bleeding, we need to know about hemostasis. And we all have studied in physiology about this, but just to brush up our knowledge, hemostasis is the body's natural reaction to an injury that stops bleeding and repairs the damage. And whenever there is a disturbance in the hemostasis, there is going to be excessive bleeding. So since we are dealing with children and newborns, we need to ask ourselves, are newborns any different? And the answer is yes. So if we look at PT and aPTT, the levels extend beyond those those that of a healthy adult. And of course, this does not increase the risk of bleeding if a child is normal. Not just that, but the concentration of the vitamin K dependent factors, other factors are also reduced to about 50% of that of normal adult values. And this is further reduced if you look at preterm infants, increasing the risk of hemorrhagic disease of newborn. And the concentrations, both that of thrombin as well as thrombin generation and thrombin inhibition are both reduced in newborn period. Fibrinogen is also low if you look into the newborn period. Platelets as such are within the normal range of that of an adult, but these platelets are usually hyporeactive compared to the adult platelets. Despite all this, the bleeding time is kind of shortened in newborns because of the increased concentration of von Willebrand's factor and increased PCV. The hemostatic system as such takes about 6 months to mature, and all the clotting factors becomes like that of an adult value, except protein C, which may take a little longer time. This is one of the most important slides for today. This is the, the coagulation parameters in term infants as well as preterm infants.
Dr. Akram, your voice is not audible.
Sorry. Will I go back or?
Yeah, the previous slide. Yes, previous slide.
So yes, this is a very important slide. I hope it was missed, but let's just reiterate. So this is a chart where we have to make sure that we check this chart before we consider a child's report to be normal or abnormal. For example, if you look at aPTT, at an older child's aPTT may be between 24 to 36. While if you look at the term infant, it may be as high as 55, and for a preterm infant, it may be as high as 80. And therefore, if we do not consider the age-specific aPTT, we may miss out on the diagnosis. If you look at von Willebrand's factor again, you can see that the child's level of von Willebrand's factor is lower than that of newborn. And therefore, this has to be looked in before we label it as normal or abnormal. So I think this was also missed. I'll just repeat this again. Vascular, if there is bleeding, there's going to be problems in hemostasis, which can include vascular disorders, platelet, coagulation, and mixed consumption coagulopathy. So coming to the vascular disorder, it can result as a condition called in conditions like scurvy. Scurvy is basically a result of vitamin C deficiency. Vitamin C is required for the synthesis of collagen type 4, and collagen type 4 is required for the blood vessels and skin. And therefore, if this is not synthesized properly, then there is going to be easy bruising and bleeding. Platelet disorders can be due to low numbers such as ITP or NAIT, or abnormal functions such as Bernard-Scholiers, where there is defective glycoprotein 1B receptor, or Glanzmann thrombocytopenia, where there is defective receptor of GP2, 2B, and 3A. Now, there can also be coagulation disorders like hemophilias and vitamin K deficiency, and there can be consumption coagulopathy resulting from DIC. So there can be problem at any stage or any step of this. Now, we all know about the primary and secondary hemostasis. So primary hemostasis is when the initial steps occur, where when there is a bleeding, there is vasoconstriction, and there is a platelet aggregation and a platelet plug that forms. Secondary hemostasis is when there is a proper, stable blood clot that forms in the site of the wound. What we need to remember is that whenever there is a defect in the primary hemostasis, these patients are going to present with skin or mucosal bleed, usually superficial bleeding such as petechiae, purpura, etc. But whenever there is problems with secondary hemostasis, usually of that of clotting factors, there is going to be deep bleeds, usually something like a hematrosis, or there may be an intracranial bleed as well. So primary hemostasis is when there is vasoconstriction and the formation of platelet plug through the process of adhesion of the platelet, activation, and aggregation. Let us go into a little detail of this. So what happens is whenever there is a damage in the skin or the vessels, there is exposure of collagen molecule to the platelet through the von Willebrand's factor. And the von Willebrand's factor attaches to the GP1B receptor of the platelet, which helps in adhesion of the platelet to the endothelium. Now, what happens is that once this happens, there is expression of or the activation of the platelet, wherein there is change of shape and increased surface area of the platelet. Now, once this happens, there is expression of fibrinogen receptors as well, which is GP2B and 3A. And we all remember that this defect can result in Glanzmann thrombocytopenia, and GP1B receptor defect can result in Bernard-Scholier syndrome. And once this activation takes place, there's going to be production of alpha granules and dense granules from the platelet, which further will increase the von Willebrand's factor secretions and production of platelet-derived growth factor, which helps in and assists in the long-term wound healing. While the dense granule is going to produce ATP and thromboxane. This is going to further activate the platelet, and not just that, but thromboxane, as we all know, is a vasoconstrictor, which constricts the vessels and reduces further bleeding. So what happens once it is activated? The GP2B and 3A receptors are going to bind to fibrinogen, which are circulating in the blood, which is produced in the liver, and it forms a platelet aggregation and results in a platelet plug. Platelet, as we all know, also contain actin and myosin, which can contract and causes compaction of the platelet plug that is formed. So this is what happens. This is the summary. So there are certain tests that we do to check for the primary hemostasis defect. It is platelet test, which may be a number test or a function test. Function test can be done by looking at PFA 200 test, which is done by a Siemens machine. And you can also look at platelet aggregation study. Look also for peripheral smear to look for the number and the sizes of the platelet, which can either be increased size or decreased size. Bleeding time is look for vascular integrity, and also test for 1 Willebrand factor by doing bleeding time, 1 Willebrand factor antigen, histological factors test, multimer studies, and factor 8 study. And we also always have to make sure that the blood sample collection is done in a correct manner and is tested within the correct and the stipulated time. Otherwise, we are not going to get the correct report. Now we know that the platelet is just a temporary measure. We also need a permanent measure, and the permanent measure comes in the form of secondary hemostasis. We all have learned about this coagulation pathway, and I'm not going into the details of this, but just want to focus on certain points. So to check for the problems in secondary hemostasis, we look for aPTT test, PT test, and this aPTT test can be elevated whenever there is problem in the intrinsic coagulation factors, and extrinsic, when there is problem in the extrinsic pathway, the PT is going to be raised. And if you look at the common pathway, both aPTT and PT is going to be raised. And so this helps us in the approach towards a bleeding infant. So there are important questions that we need to ask whenever we see a child with bleeding. First, to look if the baby is sick or not, to ask whether the vitamin K was given or not, to see if the bleeding is generalized or localized, if there is any family history of bleeding, for example, hemophilia or 1 Willebrand factor disease, to see for maternal thrombocytopenia, for example, in a mother who has ITP, the neonate has a higher chance of thrombocytopenia of up to 50%. And to also ask for any intake of drugs by the mother, which can cause increased chances of bleeding in the newborn. Apart from this, also look at the age of the bleeding. Early onset bleeding can be due to asphyxias, etc. But when the child comes late, it may be due to sepsis, etc. Look whether there is deep bleeds or superficial bleeds, which we have already discussed. Look for any conjugate hypothermia or organomegaly, which can be seen in infections like TORCH. Also see for signs of sepsis, which can result in MDIC, etc. So these are all important questions that we need to ask when we approach a child with bleeding. So this is all that we discussed just before. Now let's go into the case number 1. A well-looking 3-week-old term newborn comes with aPTT and purpura. This child is not seriously ill, and this child also do not have any hepatosplenomegaly. Some lab test was sent. Hemoglobin came to be 13.5, which is normal. The total count and differential counts were normal. Platelet count was reduced to 20,000 per cml. PT, aPTT, and D dimer was normal. The sepsis test was negative. Now there's a special test done for this child, which is a maternal HPA antibody test against fetal platelet. The fetal platelet usually containing antigens inherited from the father was positive in this case. So what is the diagnosis? I think we all know that this is a case of NAIT. NAIT basically stands for neonatal alloimmune thrombocytopenia, and this results from maternal human platelet antibodies formed against fetal platelets, which are inherited from the father. The most common of this is the HbA1 antigen found in about 98% of the population. And these patients or these people with HbA1 antigen would be referred to as HbA1 positive patient. Now, although in Asians, the NAIT occurs quite secondary to anti-HbA4, the incidence is as high as 1 in 1,000. And in clinically presenting cases, the ICH or the intracranial hemorrhage can be seen in as high as 20%. And by all means, we have to try to prevent ICH or intracranial hemorrhage. Lab diagnosis for NAIT is by doing maternal platelet type and also checking for father's platelet type. Once this is done, we have to check whether the mother has antibodies against the father's platelet antigen. Once this is seen, then the diagnosis is confirmed. For repeated pregnancies where there was cases of NAIT, you can do amniocentesis to see the type of fetal platelet antigens. Although it is not very commonly done, you can do in case of high risk patients. And you can amniocentesis is usually done at about 15 weeks of gestation. Photosynthesis is avoided as much as possible because we want to deliver these babies usually by LSCS so as to prevent any complications. But in case the parents want to go for a normal delivery, photosynthesis can be done at an age beyond 32 weeks of gestation. And we do this a little late because just in case there's any complication following photosynthesis, even if the baby is delivered, the baby's lung is kind of matured and the complications are less. So what we do here is that we collect blood sample from the umbilical cord of the fetus and see the count of the platelets. If the platelet counts are less than 50,000, we try to transfuse platelet there and then itself with an antigen negative platelet. So if there was a case of NAIT in previous pregnancy, we want to make sure that the genetic counseling is done so that we avoid intrauterine ICH. And as we know, with increasing pregnancies, the recurrence of NAIT is about 90% with increasing severity. And therefore, sometimes we have to do certain tests to find out if the fetus is affected or not. If there is a positive test, then maternal therapy can be done as well, where you want to give IVIG to the mother. And if the fetus or the newborn is affected, then you might want to give platelet transfusions if the platelet counts are very low. The risk of ICH in the newborn is high in the first 3 to 4 days, and therefore you have to keep a very close eye on these newborns, and you might want to use IVIG and methylprednisolone in case of a positive child. So in brief, the approach to thrombocytopenia can be divided into 2 parts, term baby and preterm babies. If the baby is a term baby, you might want to look whether the baby is sick or not sick. If the baby is sick, consider infections like bacterial infections, viral infections, torch infections, HIE and DIC. You also want to look for metabolic diseases like propionic acidurias. And if all these are excluded and the thrombocytopenia still persists, look for aneuploidies like Down syndrome or Edwards syndrome, and also look for inherited causes like Bernard-Salter syndrome or Lanzmann's thrombocytopenia. If the baby is well, look for the platelet count. If the platelet count is low, look for maternal thrombocytopenia. If the maternal thrombocytopenia is present, look for any chances of mother's ITP or lupus antibodies. If the platelet count is low and there is no maternal thrombocytopenia, then test for NAIT. If the NAIT is positive, then treat accordingly. If the NAIT is negative, then look for other causes and inherited causes that we just discussed. If the baby is a preterm, then you want to look whether the baby's onset was early, that is between the first 72 hours, or late, that is beyond 72 hours. If the baby had an early onset thrombocytopenia, look for perinatal asphyxias. Perinatal asphyxias usually resolve quite well. Also look for placental insufficiencies. If placental insufficiency was there, look whether the platelet count is more than 50,000 or less than 50,000. If it's more than 50,000, nothing much to be done, usually resolves quite well. If the platelet count is less than 50,000, look for infections, look for immune-mediated destruction of platelets and other rare conditions as well. If the onset is late, look for sepsis, NEC or DICs, etc., and treat accordingly. So this is basically the chart that we just discussed. Coming to case number 2, this is a 5-day-old term baby who comes with seizures. There's no other signs of bleeding and there's no family history of bleeding. There's no history of trauma, but when you do an ultrasound, you have seen that there is a large intracranial hemorrhage. This baby as such was delivered in the hospital and has received vitamin K. You run some tests and you see that the CBC, platelet, and aPTT is normal. The prothrombin time is as such very much raised in this child. So what is the possible diagnosis? As we discussed in the previous slides, PT is involved with the extrinsic pathway, and therefore this child has a factor 7 deficiency. Factor 7 deficiency is autosomal recessive condition, and they can manifest from a minimal to a severe bleeding, and the diagnosis is usually done within the first 6 months if tested properly. This child or these children are going to have GI and CNS bleedings up to about 70%. The treatment is basically to give FFP, prothrombin complex concentrate, and to give recombinant factor 7. The problem with recombinant factor 7 is the short half-life, and you might want to repeat it again and again. So now coming to a different scenario where the aPTT is prolonged and the PT is normal. So prolonged aPTT, as we have discussed earlier, defines the extrinsic pathway defect, where there is factor deficiencies such as factor 8, 9, and 11, resulting in hemophilia type A, B, and C. Also, this can be seen in severe type of von Willebrand's disease. What if both PT and aPTT are raised? This is seen in conditions like vitamin K deficiency hemorrhage resulting from deficiency of factor 2, 7, 9, and 10. It can be seen also in afibrinogenemias, factor 2, 5, and 10 disorders, and liver disease, which fail to produce clotting factors. When both PT and aPTT are normal, this can be due to platelet function defects such as Bernard-Scholier syndrome, Glanzmann thrombocytopenia, and also it is seen in von Willebrand's disease, except type 2. Factor 13 deficiency is another rare condition which can present with both PT and aPTT being normal, and for fibrinolytic disorders, which can either be a primary cause or a secondary cause such as sepsis or drugs like streptokinase, etc. And we also should always remember to ask for a mixing test to rule out any presence of inhibitors or antibodies in case of an abnormal report. So this is what we just discussed. Coming to the last case for today, case number 3, an older child who is a 7-year-old boy has recurrent epistaxis. This boy required about 4 blood transfusions in the past 2 years for bleeding, and there is no hematoma or bleeding from any other sites. There is family history of epistaxis of a father, which was seen during the childhood but resolved on its own by the time the father was a teenage. There is no interventions for bleeding required in the father's case, but this child has other 2 siblings, and the 2 siblings are also doing well without any bleeding disorders at the moment. Lab tests were sent for this child, and hemoglobin was 7 grams per dl. aPTT was raised, as you can see here. PT was normal, platelet count was normal, MCP was reduced. Bleeding time, as you can see, is slightly elevated. Mixing study came out to be normal, so there is no presence of antibodies or antibodies in this case. So what is the diagnosis? So here we do some further testings to see for the factor 8 activity. The factor 8 activity was about 35. The normal is about 50. But since this baby, but in preterm babies, the normal can be as low as 35, and therefore we need to always check the age of the child when we look at factor 8 activity. So factor 8 activity is less because this child is 7 years. Von Willebrand factor is very, very less, which is about 1%. Histocity aggregation test is abnormal. And we also should remember to do a blood group whenever we suspect a case of von Willebrand factor, because the factors depends on the different blood type group. And therefore, remember to do a blood grouping as well. So von Willebrand's factor is the most common bleeding disorder present in about 1% of the population. 80% of this people or these patients are going to have mild type of type 1 disease, which hardly requires treatment. And in these cases, most of them are going to have a normal coagulation profile as well. So as discussed, type 1 is a very mild case. Type 3 is virtually complete deficiency of the factor, which results in severe bleeding. Type 2 can be divided into 4 parts, that is 2A, 2B, 2M, and 2N. Now 2A and 2M are basically defect in the multimers of von Willebrand factor. 2B is when the affinity to the platelet is increased, and therefore there is a lot of destruction of the platelets in the spleen, resulting in ITP-like picture. And therefore, whenever you get an ITP-like picture, you also have to make sure that the von Willebrand factor, especially to rule out type 2B. Now, type 2N is a defect with the decreased affinity towards factor 8, and therefore you also need to make sure that whenever a diagnosis of hemophilia is done, to rule out type 2N type of von Willebrand factor disease. The management is to give antifibrinolytics, which helps slow down the breakdown of blood clots. You can use desmopressin, which helps release von Willebrand's antigen from the platelet and endothelium of the blood vessels. In severe cases, blood transfusions can be required as well. So this is basically what we discussed in detail. I'm not going through this again, but again, always remember to take the history of the mother for ITP, drugs, and family history of bleeding and trauma, etc. Again, we need to always remember about battered baby syndrome. Whenever something doesn't fit in right, we have to remember that this is one possibility, and we have ruled this battered baby syndrome as well. So now coming to some points regarding massive blood transfusion. So massive blood transfusion is basically conditions where you have to give a huge amount of blood transfusion, especially when there is a huge trauma or a huge bleeding or hemorrhage. So by definition, it is the requirement of more than 50% of total blood volume within 3 hours, or more than 100% of total blood volume in 24 hours. For transfusion for ongoing bleeding, more than 10% of total blood volume within 10 minutes. As we know, pediatrics is always a little different from adults, and therefore in preterm infants, it can be as high as 100 mils per kg, while in female adolescents, it can be only about 60 mils per kg. Apart from that, we also know that most of the trauma is different when you look at adults and in children. Trauma in children are usually crush injuries, and in adults, it's usually penetrating traumas, and therefore the requirement may be different in pediatric and adult. So the indications are basically trauma, surgery, especially that of cardiovascular surgeries, hypovolemia due to huge hemorrhages, and other causes like liver transplant, GI bleeding, etc. The clinical triad due to massive hemorrhage is usually hypothermia, acidosis, and coagulopathy. But we all know that hypothermia can also result in coagulopathy, because every 1 degree drop in temperature is going to reduce the coagulation factor by about 10%. And it will also reduce platelet adhesion, and aggregation is impaired, and therefore coagulopathy worsens whenever there is hypothermia. Acidosis, again, we all know is going to reduce hemoglobin and the oxygen carrying capacity because of tissue hypoperfusion. It is also going to prolong clotting time and reduce fibrinogen levels and reduce platelet count, again further worsening the coagulopathy. As such, whenever a child or a patient comes with trauma, they can have about 25% of them can have coagulopathy. And this is worsened by the systemic hypoperfusion seen in these patients. So while assessing not just the temperature and acidosis, but also make sure you look at the ionized calcium levels, because these patients are going to have low calcium. And when you give blood transfusion, because of the citrate in the blood, calcium levels are going to further drop and cause problems. And therefore, these patients may need extra calcium infusion as well. The challenges in massive transfusion protocol is to decide on the components or the type of components that will be required by the patient, and to select the appropriate amount that the patient is going to need. And of course, over how much time to transfuse whatever product has been decided. So the blood products usually used in MTP are red blood cells, plasma, platelets, and cryoprecipitate. So for immediate use, they can give you O negative packed RBCs. Within minutes, they can provide a group-specific blood group, but it takes about an hour to have a proper cross-matched blood. And whenever you decide on giving an uncrossed matched blood, you have to take the consent. So the recommendations of MTP is to take the damage control approach. Damage control approach is basically giving FFP, platelets, and RBC at the ratio of 1:1:1, especially in units. And this protocol is quite acceptable by most of the units. Fibrinogen concentrate may be required in certain conditions. European guidelines recommend that if it falls below 1.5 grams per liter, you might as well want to give, but the problem is the availability and the price of the fibrinogen concentrates. So the protocol is to provide a clear guideline, and once this protocol is activated, the blood bank will have more number of staffs commencing flowing of the frozen plasmas or the components and ordering urgent blood from blood services. So this is a small example of an MTP. Once the patient is received with a huge hemorrhage or huge blood loss, the MTP protocol is activated. So what happens is the team leader is going to call the blood bank and activate the MTP. And this leader is going to give all the details of the patient, approximate weight, age, etc., and the MTP gets activated. Once the MTP is activated, the unit is going to receive MTP pack 1. So MTP pack 1 usually contains red blood cells and FFP. For example, here, for this protocol that they have, a child less than 20 kgs with huge trauma is going to receive 2 units of red blood cells and 2 units of FFP. And once this is given, the hematologist is consulted to decide on the requirement of the cryoprecipitate. Once this is done, the MTP pack 2 comes over, which contains red blood cells, FFP, and platelet. Unless and until the team leader stops or deactivates the MTP, the blood keeps coming and the patient gets the blood whichever is required. So this kind of a protocol in place is important for a successful management of massive bleeding, and yearly or monthly or bi-yearly drills has to be done in hospitals which have trauma centers, so that this MTP protocol is effective and coordination is properly done for MTP. Tranexamic acid can also be given in this kind of an MTP situation, which again reduces the mortality. MTP transfusion does not come without any complications. As you can see, it can cause allergies, graft versus host disease, acidosis, coagulopathic infections, and hypothermia. Hypothermia is something we want to prevent as much as possible, and this can be done by using high-capacity commercial blood warmers such as this. And by doing this, the hypothermia of the blood is reduced, again, thereby reducing the coagulopathies. So today's take-home message is know the age group of your patient, because this is going to guide you. Age-appropriate values have to be taken into considerations. Know what to ask when you have a child with bleeding. Collection of the sample has to be done correctly, because if not, you are going to get wrong reports, which will not give you the correct diagnosis. Clotting time, as you have seen, we have not mentioned in any of the previous slides. It is so because the clotting time is no more done and is not useful when evaluating a child with bleeding disorders. At least a CBC, peripheral blood smear, PT, aPTT, and if possible, TT should be done as an initial workup. In a country like ours where we still have home deliveries, make sure that the child, when he comes to the clinic or the hospital for the first time, should receive vitamin K as soon as possible. Thank you. Over to you, Sir Nitin, if there's any questions.
Thank you, Dr. Akum. It was a very good presentation. And there is no question in the chat box till now. I would like to request all delegates to please put up their questions. And I would also like to reinforce here that there are various cases. In fact, in our clinical practice recently, we have lost a child who was a case of massive blood transfusion just because our blood bank was not equipped enough to give us right blood products, and kid was 3 kg and severe volume loss, although all parameters were managed. But when they start bleeding, they bleed like anything. So whenever you put an order in cases where you are suspecting, when volume is at least more than 70 ml per kg in a child and more than 90 ml per kg in a preemie, then always order for one PRBC, one FFP, and one platelet in one go. Do not and get all the bloods. Start with FFP, platelet, and PRBC, and immediately as soon as possible as your resources allow. But anticipate complications. Rajdeep Rathod is asking for dose of Trenexa. So, Dr. Akum, do you wish to answer?
I think if I remember correctly, it's about 10 milligrams per kg.
Yeah, 10 milligram per kg, ceiling of 500 mg.
Sir.
And it is recommended only in trauma. Very few people have started using it during dengue, but it has no conclusive report, no conclusive any relevance of this intervention has not been shown any improvement in the patient profile. So if it is trauma, then yes, it is helpful. If it is bleeding secondary to other causes, then it is not that useful.
Agree, sir.
Okay. So we have Shalendra, who is asking how to manage dyselectrolytemia during MBT. Shailen, like you manage dyselectrolytemia, you have to manage in the same way, and there is no other way. If it is hyperkalemia and if it is hypocalcemia, then calcium gluconate is an answer, which will be useful. Also, make sure that it should be freshly collected blood, should be CMV, and other parameters should be checked. And you should be in a position to identify hyperkalemia induced cardiac changes, because while you're transfusing, this case is managed in ICUs, NICU or PICU, and 6-lead ECG should reveal the presence of tall T. And if you pick at this moment, you will be in a very good position to identify hyperkalemia, and reversal is good when you intervene. Always remember, after hyperkalemia, you are bound to see hypocalcemia and associated further complications. So, like you mentioned, like in any case, not only in MBT, even in loose motions, if hypocalcemia, hypernatremia, or hyponatremia happens, you are going to manage in the same way. There is no difference, no change. And mainly these electrolytes, they affect action potential, they affect gradient across the membrane, so they are bound to cause changes in ECG or in EEG. So electrophysiology is hampered, is affected, will show results, will show symptoms. So be uh, open and understand the pathology and intervene after anticipation. I think, Dr. Akum, there are no further questions. With this, we will close our session.